So thank you again for putting up with our repeated inquiries and harassment. Much appreciated. So we're going to jump in. We're going to start with Dr. Lisa Berry, who is going to really talk about her ARCH pilot that was instrumental in, I'm just, we try to claim, Lisa, we're just like claiming your R01. Oh, see, this is great. So, but seriously, it's really, we're thrilled the connection. So Dr. Berry is a chronic disease epidemiologist and associate professor at the UCONN Health Center on Aging, and also has served as an ARCH Network member of our executive board, and has really provided invaluable insight and leadership for the last several years to the network. So Lisa, thank you so much for sharing with us, and I'm going to turn the mic over to you.
Okay, great. No, it's a pleasure to be here today. And let me share my screen here. Let's see if I can figure this out. Can you see my presentation?
Yes.
Okay, hold on.
Good to go.
At two screens, and all right, here we go. Oops. Okay, so let's see. Oops, there we go. Okay, are you just seeing one slide right now? Just the title?
You're in presenter mode, but that's fine.
What do you do? Display settings or something? Oh.
Yes, there you go. Yes.
Aha. Okay. You'd think we know how to do this after so long. So I'm very happy to present today on kind of an update on my study that was funded by the ARCH Network. And that study is called Assessing Geriatric Conditions as Novel Risk Factors for Dropout Among Those Seeking Treatment for Substance Use Disorders in Mid to Late Life. Long title, The Role of Incarceration History. Okay, and I certainly want to acknowledge the ARCH Network. So I would certainly not have been able to do this research without ARCH. Thanks to the Root Center for Advanced Recovery. Those are the substance use disorder clinics in Connecticut where we conducted this research. And just thanks to my co-investigators who are Doctors Lance Bauer, Megan O'Grady, and Kristen Zajac. Okay. And as I'm sure many of you know, there's a very close relationship between substance use disorders and incarceration. And among incarcerated adults in the US, between 58% and 68% have a substance use disorder. So at the same time, we're currently experiencing kind of what I call a convergence of factors. As we all know, there's an increase in the number of the incarcerated persons who are in mid to late life or age 50 and older. Rates of substance use and dependence among incarcerated persons who are in mid to late life are actually increasing more rapidly than those among their younger peers. And at the same time, just in general, not necessarily among incarcerated persons, but in general, there are greater lifetime rates of substance use among people in mid to late life than same-aged persons in earlier cohorts. So between 2000 and 2020, the number of those age 50 and older with substance use disorders increased from 1.7 to 5.7 million. People age 55 to 64 have the highest rate increase in opioid-related deaths. And because of that, rates of treatment for substance use disorders have grown tremendously in this age group. So in thinking about treatment for substance use disorders, people who are in mid to late life actually tend to have lower dropout rates than younger people. However, dropout is still common, and it's even common in those that have been court mandated to go to substance use disorder treatment. Rates of early withdrawal or patient non-adherence among those in mid to late life range about from 30% for those with alcohol use disorder, but up to 67% for those with heroin or prescription opioid use disorder. And withdrawing from treatment is associated with further negative outcomes, which include relapse, overdose, and future incarceration. And that could either be recidivism or a new incarceration. And despite that, few studies have evaluated factors that are associated with substance use disorder treatment retention among older people with substance use disorders. And what we do know comes from a large data set called the Treatment Episode Data Set of Discharges, or the TEDS-D. This is an administrative data set which collects annual data on discharges from publicly funded substance use treatment programs. So it's a great resource because it has, tons of data. However, it's administrative data, and administrative data does have its limitations. So, for example, it doesn't include information on factors that might be indicative of accelerated aging. So, for example, poor balance or slow gait speed. And these factors might be relevant to treatment retention in older persons, but we can't study them using the administrative data. Okay, so that brings me to my ARCH pilot study objectives and our aims. So the overall objective, as when I submitted the grant, and we'll talk about how that might have changed over time, the overall objective was to determine the feasibility of identifying geriatric conditions in people age 50 and older who are seeking substance use disorder treatment after mid to late life reentry. So after, reentering the community after an incarceration, and looking at these geriatric conditions as a novel means of distinguishing who might be at greater risk of substance use disorder treatment dropout. So our specific aims were to compare a severity of geriatric conditions among those with and without a recent history of incarceration to healthy controls. So looking at those who are in substance use disorder treatment, but separating out incarcerated, didn't have a recent incarceration, and then comparing it to a control group. And then determine if the severity of geriatric conditions is associated with dropping out of substance use disorder treatment, and if dropout is even worse among those with an incarceration history. And stop me at any time too, if you have a question, certainly. So I'll tell you a bit about our study sample, what we had planned, and what actually happened. Conducting pilot studies, this is often a bit of trial and error that you're learning as you go, and you sometimes have to modify things. Things might turn out a little bit different than you anticipated. So we were able to partnership with the Root Center as we had planned, and partnering with those community stakeholders was absolutely critical, and they were great partners. We tried to get participants who were age 50 and older. And as I'll show you in a minute, what we found were that the controls were considerably older than the individuals in treatment. So we can talk about that in a moment. We recruited our controls through flyers in the UCONN dental clinic and through the UCONN outpatient psychiatry unit. And that was great. We didn't have any problems getting our control population. And then we were trying to recruit individuals, up to 40 individuals, who were initiating substance use disorder treatment. So we were trying to get people who were within 8 weeks of starting, so who were age 50 and older and essentially had just started. And it might have been that they had been in treatment before, had been discharged and were starting again. It didn't necessarily have to be the first time ever treatment. However, what we found that was that enrolling people at treatment initiation was really difficult. It's a challenging time for people. It just wasn't, at least again, in our clinics that we were in, wasn't a great time for people to be interested in participating in a research study. So, and it was also harder to find people in terms of that age group with that specific criteria. So we had to modify our protocol ultimately to anyone who was age 50 and older, who was in treatment and was on a stable dose. So they had to be on a stable dose of methadone treatment for at least a week. We also found that we had to increase our compensation a bit, so from $75 to $125. And we also incorporated snowball recruiting. So for example, if someone participated in the study and then they recruited someone else who ended up participating in the study, that first individual would get an additional $25. So people could do that up to 3 times. And all of that helped considerably. And we had also planned that we would get 20 who had been incarcerated in the past 3 years and 20 who were never incarcerated. However, we were finding, kind of based on what I just said in the beginning, that the majority of these individuals have histories of incarceration, and it was difficult for people who were interested in participating to try to, figure out, who, oh, you were incarcerated 4 years ago, so you're not eligible. It made it difficult, more difficult, I think, to partner with the substance use disorder facility and be kind of so picky, if you will. And so we opted to enroll regardless of incarceration history. So they could have been incarcerated, back when they were 18. They might never have been incarcerated, but we weren't just capping it at 20 and 20. This is really, have to go through this. It was just to show you how many people we called and screened and who were completed. And this was the changes that I mentioned. So before we made those changes in recruitment, you can see going from calling 13 to having only 1 of those show up. We transitioned to having talked to 45 people and essentially having 35 of those 45 show up. So much different. Okay, so just to kind of explain the 2 populations. So the study is still ongoing, although we have almost reached our max of 40 individuals in the substance use disorder group. But for the purposes of this presentation, we have 37 people in our substance use group and 10 controls. As I mentioned, the age difference between the controls and the treatment group was substantial. So pretty much a 10-year age difference. And you can see that the controls ranged from 58 to 79, and here ranged from 50 to 68. And we also found, if we looked at people, if we tried to look at those who were older than 55, that comprised everyone in the control group, but about 60% of those in the treatment group. So again, that 50 to 54 range is really a big group in the substance use group. We had kind of similar proportions of males and females, and we had a relatively diverse sample kind of in both. Education was a bit less in the substance use group, and no one was a smoker among the controls, whereas 76% were smoking in the substance use group. And right now, I only have data for the substance use group for the moment regarding the chronic conditions, but just wanted to show that on average, these individuals had nearly 3 chronic conditions, which, considering their relatively young age, is definitely high. 58% had at least 3 chronic conditions. This just gives you an idea of the prevalence. Hypertension and arthritis and hepatitis C were the most common, but we were also seeing things like stroke and a heart attack, which I thought, wow, 20% of these individuals have already had, a heart attack. So definitely concerning. In terms of the incarceration history, as I mentioned, the majority of them had an incarceration history, so about 74%. There was a wide range of how long people had been incarcerated for in their lives, so ranging from never incarcerated up to 228 months. And almost all of those who had been incarcerated had been convicted at one point or another for a drug-related offense, so 85% of them. And 44% of these individuals who had been incarcerated had spent some time in solitary confinement. And in terms of the treatment factors, just to give you an idea of what was going on there, 11 of these individuals, so almost 30%, had started their treatment in the past year. However, the range of people in treatment, some started back all the way from 2001 up until the very recent past. Again, it was a methadone clinic. When asked what substance gave them was their most major problem, heroin was by far the first. Others had multiple drugs, other opiates, cocaine, and just 3 individuals. One had alcohol, one said benzos, and one said alcohol plus another drug. Half had an overdose in the past, and we had a wide range of time that people had been abstinent. So ranging from have essentially never been abstinent in their adult life to up to 15 years. And now we're back in treatment. And just to show, about 56% initiated use at age 30 and older. So 40 and older, I think there were only 2, but so, you know, after the age of 30, people are starting. Again, perhaps not surprising, in the substance use treatment group, they had considerably worse indicators of poor mental health. So this is the generalized anxiety disorder scale. Again, statistically significant. You can see quite a difference there as far as the PHQ-8, a mean of almost 9, and a PHQ score of 10 or more is indicative of clinically significant depressive symptoms, and 46% of the treatment group met that criteria, and no one in the control group. Now, when we looked, though, between those with and without an incarceration, we didn't see any difference, so the scores were quite similar. Okay. And so pointing out here, we saw one difference, but the similarities, I think, are actually what ends up being striking. So these are some objective measures of physical function. So those could be indicators of accelerated aging. And the substance use disorder treatment group had either similar or worse indicators of physical function, although they were, on average, more than 10 years younger than the controls. So in terms of the, this is called the Tinetti balance scale. It goes from the final score is up to 28, but here substance use disorder individuals had significantly worse balance. Here, for all of the other things that we considered, we ran a Berg balance score. We looked at grip strength using a dynamometer, and we administered the short physical performance battery. And so I'm just presenting the results from gait speed. It's a 4-meter walk, and chair rises, where people have to rise out of a chair 5 times in a row without using their hands. And really, there were no major differences, but I thought that was, again, somewhat striking in that this was a considerably younger sample. And then when we looked at the differences in the treatment group among those with and without incarceration, things were really pretty much the same, despite having been incarcerated or not. So just a brief summary of the findings. We found that it was feasible to partner with a substance use treatment clinic and also to recruit participants that were aged 50 and older. However, we found that it was really difficult to get participants who were just starting treatment. So kind of going back to the original aim, where we were focusing on dropout, it really made dropout much more difficult to assess as an outcome, because you had people who were starting, had been in treatment for so many different time frames. So we, at this point, we're focusing more on the geriatric conditions and differences rather than focusing on the dropout. We found that increasing the compensation and the snowball recruiting helped. I mentioned that. To the best of my knowledge, this is the first study to assess objective physical function in people who are receiving substance use disorder treatment in mid to late life. So that we also found that it was feasible to administer these objective tests of function in the clinic, and people were receptive to doing them. They were safe activities. We saw that there is potential evidence of accelerated aging as indicated by their functional status, such that they had similar functional status to those who were significantly younger. We didn't see differences by incarceration status, but really most had been incarcerated. So that made it a little bit more difficult to compare given the small sample size. Whoops, sorry, I think that's it. And then in terms of next steps, so one thing that I didn't discuss just because of the interest of time, this study also incorporated a qualitative component. So we spoke to stakeholders, so individuals who are providing patient care at the clinics, asking them about questions regarding the older individuals or people in mid to late life who are receiving treatment, if they had any specialized programming for them. And right now we're in the process of going through those qualitative findings, but our preliminary evidence indicates that some of their concerns about this population were the age differences with other patients and with the providers. So it's hard for someone who's 60 years old to come in and sit down next to someone who's 20 years old, or have someone providing care that's, you know, so much younger than them. They also have a lack of provider training and age-specific programming. So they really had, really didn't think about this population as having any particular unique needs, and just basically out of lack of education. And they also said largely the focus on the opioid crisis was in young adults, but as I mentioned, there's really this tremendous increase in those who are older that are seeking treatment for substance use disorders. So, trying to get more focus on this population is something they were interested in. So in terms of our next steps, we're going to be working with these stakeholders, hopefully to develop and test an intervention that can help to improve treatment and recovery outcomes in people who are seeking substance use disorder treatment in mid to late life. And so now that we know that it is feasible to recruit these individuals, and that it's feasible to administer these different measures of function, then we'll move on to working with the stakeholders potentially to develop interventions around some of the concerns that they mentioned. So hopefully we'll see a grant submission coming from this in the near future. So it's kind of a brief overview. Still, like I said, in the process of finalizing the data collection and analysis, but this has been really eye-opening work too. These individuals have so many stories and just a lot of difficult life experiences, and again, having someone focus on their health is appreciated by them. So I'd be happy to take any questions if anyone has them.
Thanks. Thank you so much, Lisa. Yeah, we have a few minutes for questions. If anybody wants to, you can go ahead and feel free to unmute your mic or type in the chat.
Oh, can I ask a question?
Sure.
Yeah.
Oh, hi. My name is Ben. I'm a geriatrician and addiction medicine physician.
Yes, I'm very familiar with your.
Oh, yeah. So thank you so much for presenting, because we, I did a similar study in New York, measuring geriatric conditions. And yet we ran into the same issue with the opiate treatment program, was that people who were just starting, it was hard to recruit them, because then oftentimes they would drop out. And so our sample was mostly people who had been on methadone for like decades. And so very different population. And I think especially the question you're asking is, you want more of the people who are just starting treatment.
Exactly.
And it's great to see that you're able to do a lot of those battery, like objective functional tests, because that's, I tried to do it. I was early in my career, so I did some of them wrong. And so that's why I couldn't use any of that data. But so it's really glad to see that you're doing that. And then also we're doing qualitative interviews now with stakeholders at OTPs here on older
Oh, great.
adults. So that's something we might want to connect on.
Yeah, absolutely. No, I would love to.
I guess so. If for your study now, are you collecting any other data about geriatric conditions like falls or incontinence or things like that?
No, we didn't collect that information. So it's mainly just the common chronic conditions. And then we have, mental health questions. We have a large battery regarding their substance use, both their history and treatment, things go, how long they've been in treatment and how many times they've been in and outpatient hospitalizations. But yeah, we don't have more information on things, other syndromes like urinary incontinence, which would be great. We did administer the go, no-go test for kind of executive functioning or inhibition, and I haven't analyzed that data yet. So I can let you know what happens with that.
Okay, great. Yeah, I'd love to connect about this work in the future.
That would be great. Thank you.
Really quick, Lisa, I just had a question. So the majority of individuals in your sample initiated use after the age of 30. So that's really also, I think, very interesting from my perspective, because we always hear, it's like around mid-20s, majority of people sort of age out, so to speak, of substance use, but then more and more people initiating at older age groups, I think is not sort of the norm that we hear a lot of the time. So that was another interesting thing that I saw.
Yeah, I was surprised by that as well, really. So yeah, it was more than half for age 30 or older. And my colleague, Kristen Zajac, who is one of the co-investigators, her focus is on emerging adults. So that population from 18 to 25. So it's interesting. It's that, she was somewhat surprised too, to find this.
Stephanie had her hand raised. Hi, Lisa.
Hi,
Thank
Stephanie.
you for this important. I'm just already excited about all the things that I will have to cite in your work. So I was curious, I got some strange feedback recently on an article about how I captured or how I measure chronic conditions. And I was curious, how did you get those I guess measures? Were they self-report? Were they
Yeah, these were self-reported measures. So
right. Like I've never heard of that ever being controversial. And so that's what we did. We just had a list of conditions and asked and they were like, are these objective? And I was like, I'm not sure what you're asking.
Has a doctor or healthcare professional ever told you that you have, one of the following? And of course, there's just like there's limitations with medical chart data. There's limitations with self-report, but we've used that pretty regularly.
Okay, thank you. I appreciate that.
Did I stop sharing or am I still sharing? No.
Oh, can I ask another question about the substance use slide?
Sure, of course.
So I found that interesting that I guess most people had a issue with heroin, because here it's pretty much all fentanyl. So was fentanyl didn't really come up much for your sample? Or
yeah, that wasn't specified, and I'm trying to look at the question here. And let me see. We use the addiction severity index, and so that goes through, the specific drugs. But it might be, and even in terms of the other, people weren't mentioning that, but that is interesting. So that's something I think we definitely need to ask about in the future.
Okay, well, thank you so much again, Lisa, and look forward to future work in this area. I am going to turn it over to Jamila Henderson, who's going to introduce our next speaker.
Thanks, Nick. Can everyone hear me okay?
Yes.
Loud and clear.
Perfect. I was having audio issues earlier. I apologize. So thank you, Lisa, for that presentation. Good afternoon, everyone. I'm Jamila Henderson. I joined the AMEN research team, research and evaluation team, and the Arch Network team over the summer. And I have the pleasure of introducing a former colleague of mine, Molly Pickard, who is a research manager with the California Policy Lab at UC Berkeley. And she is going to present on translating research into policy by highlighting her work with California's Committee on Revision of the Penal Code, or CRPC. In 2020, California created the Committee on Revision of the Penal Code to reduce overcrowding in prisons and simplify and improve California's penal code. The California Policy Lab, or CPL, is serving as the research partner to the CRPC. And at CPL, Molly manages the criminal legal portfolio, and her work primarily involves working with CRPC. She holds a Master's of Social Work and Social Policy from UPenn and a Bachelor's from St. John's College. Thanks again, Molly, for joining us, and I will turn it over to you.
Great. Thank you so much, Jamila. Excited to be here and excited that there is at least one cat in attendance. Love to see that. So let me just share my screen. Okay. Okay, it's on the wrong, oops. The wrong monitor. Okay, I'm going to be looking over here because it's open in the wrong monitor, but I'm paying attention to everyone on my other screen over here too. So I'm going to do a quick overview of some of the contextualizing. Jamila did a very quick overview of some of the contextualizing of who we are and the work that we do, but just to add a little bit more, and then I'll talk more about the actual pathways to impact that we have as researchers who are working directly with a legislative body. So first off, I'm just going to start with the mission overall of the California Policy Lab. So we generate research insights for government impact. We do this through hands-on partnerships with government agencies, and CPL performs rigorous research across issue silos and builds the data infrastructure necessary to improve programs and policy that millions of Californians rely on every day. I've also been told that not everyone here is from California. So if I use any California specific terms or anything, like please jump in and tell me to clarify. So more specifically, as a whole, CPL focuses on many different issue areas. But as Jamila said, I work specifically with the criminal legal system, but we also work with labor and employment, homelessness and high needs populations, the social safety net, as I mentioned, the criminal legal system, education, and health. And as I'm pretty sure everyone here knows, all of these things intersect. So there is no real one issue that any of us work with. Obviously, the criminal legal system also deals with social safety net, health, labor, employment, pretty much everything listed here. So again, just quickly about what CPL does, which is also relevant to what we do with the committee, is developing research agendas, cleaning, linking, and analyzing data, conducting rigorous research, engaging in long-term collaborative learning with our research partners, connecting to other resources and partners, and then building long-term research infrastructure as a common good. So we also aim not only to do projects with specific partners, but also to host data. So if there is anything that I talk about here that seems of interest, people can also reach out afterwards and see if any of the data is available to request, and then you can also work with it. Very quick overview also of who the team is. I am clearly not the only person that works on this team. So we have 3 PIs, Mia Bird, Joanna Lako, and Stephen Raphael. And then the team of analysts is me, Alyssa Skog, Thomas Sloan, and Nafara Reish. So just giving everyone a quick shout out. And I'm not sure how familiar anyone here is with sentencing commissions or sentencing committees. Every state has something that deals with sentencing. Not every state has a specific sentencing commission or committee that's built into legislature. They're relatively new. The first one, I think, was developed about 50 years ago, so newish, depending on your definition of time. But the California one is only 3 years old. So we are very new in relation to a lot of other sentencing commissions or committees that exist in the United States. And we are specifically a legislative body. Well, I'm not, but the committee is specifically a legislative body, whereas sometimes sentencing commissions or committees can be people who just take what is turned into legislation, and then they are more of like a teaching body where they teach people in district attorneys' offices or court systems how to implement the policies that are made. We more specifically turn research that the California Policy Lab does into those policy recommendations. It's also a very unique situation because it is written into the statute that the committee can compel a state agency to give data. So there isn't any state agency that's allowed to say, no, we won't share our data. We still have to go through the obvious like DUA, IRB, all of the actual protocols, but there isn't a state agency that's allowed to say like, no, we don't think this research is important and we won't share our data, which is a very unique opportunity and not one that any of our other research partners have. This is very specific to the committee. And it also offers up the opportunity to push forward a lot of transparency of what's happening in the criminal legal system, which is very exciting for us. Also, I'm going to do a quick shout out for the people who are on the actual committee and explain how it's made up. So the committee is typically 6 members. Sometimes it changes, but they're all appointed by the governor directly. And there always has to be 1 assembly member and 1 Senate member on the committee at any given time. And then it's also made up of committee staff who are the people that we work with most directly. And I'm going to go to the actual process of how the committee works. So there's 6 public hearings a year. It's typically like once every other month or so. Again, sometimes it changes just based on people's schedules. But anytime the committee speaks, it has to be in public. So they can't talk about any of these issues just in like a side meeting or an email. Everything they do that discusses these legislative issues has to be in a public forum. They have 2 to 3 panels of people, relevant professionals, including they always make sure to have a point of having people with lived experience talking. There's longer presentations given by experts, usually like 30 to 45 minutes of presentation of relevant research. And then each committee meeting ends with public comment. They also have an annual report, which the CPL helps with, which puts recommendations out, which then turn into, hopefully, legislation and policy. And then special reports on topics related to yearly recommendations. I think the first one they did was to try to end the death penalty in California. There's another one about 3 strikes and trying to eliminate or change the way that 3 strikes sentencing happens in California. So some examples. So our work with the committee, as I mentioned earlier, is similar to the work that CPL does as a whole. They get this data from these state agencies, and then we do the work to clean, link together, and work with this data. It is all administrative data. We don't do any sort of like focus groups or data gathering ourselves. We only ever work with purely administrative data. And then we design studies to address the key committee questions. So questions will come up in these public hearings where maybe someone will be speaking about something, and then a committee member will say, you know, like, that's a really interesting question. Like, how do we go about this? And so then we would step in and work with the committee staff to say, like, what are the relevant questions? Like, what does the data have? What data do we have that could answer any of these questions? And we work with them, sort of like build out research questions in that way. And then we also synthesize existing policy relevant research findings. So again, I think most or everyone here is some sort of academia. The people on the committee are very much lawyers. So we do a lot of work with just sort of taking maybe papers that they find that they think are interesting and helping understand just what things mean, you know, what a p-value is, like, are things relevant? So we do a lot of that work as well. And then presenting the research in policy briefs and reports. And then we also try to present at committee meetings as frequently as possible. And then connecting committees, the members, with additional resources and partners. So to go into the actual pathways of impact and the ways that we can help inform policy and legislature. I want to start with the two biggest hurdles, which aren't on this slide, but I think are very important to talk about. The biggest one that I find, well, they're both equally big, but the first one is the different sort of goals that people in academia have versus politicians. I know, again, I think this has kind of come to as a big surprise to many people, but people who work in academia, I find, really want to like push forward knowledge and like build to our understanding of knowledge and like what already exists. And politicians sort of just want to like, you know, get a bottom line and get a law written. It's not so much necessarily based in evidence, not so much based in research. And so these are two just like very different interests that we have to work to balance. And relatedly, the timelines are just very different. Academia, it takes a long time to conduct like very good and rigorous research. It's not something that happens overnight. It's not something that happens in a week or a month, but oftentimes we'll have people from the committee come to us and say like, hey, I have a meeting with like X, Y, and Z senator tomorrow. Like, can you get me this number or figure? So the timeline is just like very much faster and not on the same sort of scale as what I think good research is on. So those are sort of big picture roadblocks and difficulties that I think are important to keep in mind when I'm also talking about the pathways to impact and the ways that we can impact policy. So relatedly, technical assistance, I think, is the biggest one and the one that has the most direct policy impact. So that's sort of like when I was just saying a committee member comes to us and says, we have a meeting tomorrow, what numbers can you give us? And we just have to sort of like pull any sort of, it's usually like very small like counts of things. Like they'll say, we want to have a bill that changes the way that, you know, burglary is sentenced in California. And so we have to very quickly just pull the number of people who are currently incarcerated on burglary to see if they make this policy recommendation, like bottom line, how many people are going to be impacted by it. It's not necessarily rigorous, as I said. It's hard to make any sort of like causal implications or really anything from those sorts of just like, here's a number and here's the amount of people that might be impacted. But it is ultimately what is the most impactful in terms of like, that's the number that is used if they want to make a recommendation. If it's 0 people that are going to be impacted, they're less likely to make a recommendation. Similarly, presentations in front of the public committee hearings and talking to decision makers and writing reports. So these are sort of the like longer term research that we do. We do aim to still do causal work in longer research, even though it does take more time and it might miss policy windows. It is still a really important part of doing research, obviously. So we aim to do that. And there is a hope that sometimes if a policy window closes or a bill isn't picked up, that by doing this research and having a causal paper, we can influence the next cycle and say, a bill wasn't picked up, but look, we have this research, and this is a more direct point of evidence of why maybe we should try to have this bill again. And as I said a little bit, the process is really, legislators are interested in a topic, the committee wants to make a recommendation on that topic. They'll ask us for background research and information, and then a recommendation is made. And then further down the line, once the committee is around for a little bit longer, the hope is that we will then be able to study the actual policies that we recommended. So it's a full circle. We get to recommend things or help recommend things, and then do studies to actually make sure that those recommendations are working in the way that we hoped that they did. So to talk a little bit more about the more indirect impacts, public opinion management is a pretty big one. So a lot of things, I'm not sure where everyone is from, but you might have heard in the news, there's all this sort of like uproar about San Francisco is so dangerous. There's all this crime in San Francisco. I've had family members reach out to me and be like, I'm scared for you. I should tell them like, that's not quite really what's happening. So part of the job again is to like put out reports about what is actually happening with crime, and just sort of debunk what people think or what the media is saying or what just like public perception is, in order to redirect to the actual issues that are happening. So if there is specific crime that is going on, I think, you know, we were just talking about substance use disorder, like we should be focusing more on the ways to be helping people with substance use disorder versus like being scared that all this crime is happening. So refocusing and then putting out reports that will lead to more positive policy changes. Sort of similar to that is managing potential public backlash to reform. Again, I think there's a lot of instances where, especially during COVID, I think there was a big sort of scare of like, if we let out all these people, there's going to be all these like quote unquote criminals and they're going to be running around and crime's going to go up. And so putting out reports and research saying like, this is not actually what happens. Like crime doesn't just start like soaring just because you let people out of prison a little bit earlier than you would have otherwise. So also part of this is educating people on how to use and think about research. As I was mentioning earlier, we work with a lot of lawyers, we work with a lot of politicians, and sometimes it's helpful just to like have conversations about how research works, if something's causal or if it's not causal, if you can say something's causal. It's a big thing that the people that we work with love to say is they love to just put causality on everything when that's not exactly how it works, and we can't always do that. And just the research that CPL does in general is also very useful to the committee. And I think that this is probably hopefully a big takeaway that other people who don't work directly with legislators can keep in mind, is that if you do work in a state where you have legislators that are interested in research, like they probably are reading your research. The committee that we work with reads constantly about the research that's happening in the state, and they use research from all over to help inform the recommendations that they're making. And as well with CPL, we do other research that's not specifically with the committee, and they will use any of that research to make more relevant policy recommendations. So I have two examples here. One is Make It Right, which is a diversion program in San Francisco, and they had a recommendation to broaden that program to other counties. And then similar PAR, which is a pre-arraignment representation and review, which gets public defenders to people pre-arraignment, like as soon as they're booked, to help with services. And we've done research on that program evaluation, and found it's very effective on helping people to get the services they need and to have better outcomes when being in the criminal legal system. And so they also made a recommendation to broaden that and put more money towards programs like that can positively benefit people. And so the last point here is to help interpret widely read reports. So there is a report that came out of Yolo County in California about their bail program. Again, it was written by a lawyer. So I don't know if there's any lawyers here, but I know that they say that they don't like numbers and they're not good at numbers. And so you have a lawyer that writes a report, and it's not going to be the same report that you would have if a researcher wrote it. So there's a report that came out. It was done in, I will say, just a way that we wouldn't have necessarily done it, but it was very widely read, and it was cited in a lot of public legislative meetings, not just the ones that we work with, but also just like other legislatures. It was just, everyone was saying how horrible not requesting bail is and letting people out, when that really wasn't the takeaway that should have happened from the actual numbers. So we do a lot of work to then sort of say like, yes, this research exists, but also let's do other research with similar data and see if maybe there's different outcomes. So go quickly just over the actual reports that we've done, and then I want to leave time for questions and comments. But the larger reports that we've worked on is looking at crime in California during the COVID-19 pandemic. As I've mentioned, we've done work with the 3 strikes in California, seeing what the impact of 3 strikes has been on elongating sentences, sentence enhancements in California, which I think sentence enhancements exist in most states, but it's a very specific problem in California, where enhancements are just sort of like packed on to your original charge. You'll get a gun enhancement and a drug enhancement, and just they really sort of like skyrocket sentences. And then looking at how consecutive sentencing works in California. And then we also do shorter like fact sheets, which we call our by the numbers series. And these are on the request pretty much specifically by the legislature, because they want sort of like easier to understand and quicker things to read than our longer 50, 60 pages reports. So we we have these shorter, like 5-page fact sheets. We've done one on COVID and incarceration, racial and gender disparities and police stops, the structure of California's felony offenses and sentencing triads, and we're just about to finish one on the trends and applications of California's nickel prior enhancement, and that's hopefully the first in a series of more in-depth looks at enhancements in California. I have a page of actual recommendations, but I'm going to just skip this to go to questions. So if you're interested in learning more, you can sign up for our CPL emails or the committee emails, or you can feel free to contact me directly to ever talk about data or policy or anything else you find interesting. Stop sharing.
Thank you so much. We have a few minutes for questions, especially from our lawyers in the room.
I love lawyers, just to be clear.
It's okay. I totally understand it. As somebody who bridges the two worlds, sometimes I see what like legally trained people do in the context of getting like scientific research or any kind of data. And I really wish that they would start providing like how to evaluate data in law school, because I think it gets used a lot. They don't teach us that though. We learn it through wonderful people like those on this call.
We had a, I'm sorry.
Oh,
There was a question in the chat about funding for the center.
So that's a great question. The center itself is funded by a lot of grants. It's usually grants specific to projects. We got funding from Arnold Ventures for the first 2 years of this partnership with the committee. And then after sort of demonstrating the viability of our research and this partnership, we ended up getting state funding. So we now are fully state funded. Well, this project is fully state funded for the next 3 years. And then again, if we continue to demonstrate the goodness, like benefit of this work, then we'll continue to get state funding. But it's very project specific. But the committee itself, the hope is that it will be a permanent legislative body. So the goal is to continue to get people less incarcerated and for shorter sentences, and that's a long-term project. So,
question about how did the committee get legislatively mandated? So for many of the rest of us, the very notion that asking for data from a state agency and they can't refuse to give it to you, that's so foreign to me living in a state like Arkansas. So I'm fascinated to know how that came about, where you have this committee that's legislatively empowered to essentially demand data from people.
Yeah, that I think is like purely from the fact that their governor at the time, who was the one that started this body, just thought it was necessary. That was just like from him. He just knew that there was no way of making these changes if there was no access to the data. So other than, I guess elected governors that are interested in data, that's sort of like a bigger picture, I think, problem with data sharing in general in the United States. But again, it is very specific to California. We work with other sentencing commissions and committees. Like the closest one, I think, is the one in New Jersey. And they don't have anything even remotely like this. They have to do the same sort of process of requesting data as we do for all of our other projects, of going to the agency, having a project proposal, requesting the data for a specific project, and then, working from there. Whereas we can do any project we want. We do not have to get any project approved. It's really just sort of like free reign of whatever we can imagine with the variables that we have, which is truly like unlike anything I've ever had access to either.
Any other questions, comments from anyone?
Molly, not to put you on the spot, but is there like a particular policy recommendation or issue area that you worked on with the committee that you're either like proud of or that you saw as a win or success story?
Yeah, I think that a lot of the stuff that we're doing, especially around alternatives to incarceration. And as I mentioned, like the PAR program and getting representation to people earlier, like that is really sort of a lot of the research that I've had the privilege of working on that has had direct impacts, and seeing that it's also some of the legislature that's being taken up feels like really great, and to know that that's being supported by other people in California and by the budget committee and stuff like that, and people are really seeing that that's an important part. Feels like a great shift away from incarceration to like more holistic views of just how people operate in the world. So I think that that's something that I feel proud of, and thank you for the question.
Mhm. Okay, well, we are right about at the top of the hour. Thank you all very much for spending part of your Friday with us. Thank you again to Lisa and Molly for presenting. And I hope everyone has a wonderful weekend.
Everyone.
Thank you.
Bye.
Bye.